Hi everyone, good evening students. Welcome to the must know session for anesthesia, and I was listening to JP sir's session and it was electric, and so I know you all are charged up. He has his own swag of delivering his class. So let's discuss the most important topics that you need to remember in anesthesia. So I'll start with the most important topic, which is cardiopulmonary resuscitation, and of course I'm just gonna brief you about everything. It is a coverage of everything in short. So let's discuss first the changes that have happened in the 2020 CPR. In the BLS, a sixth link has been added into the chain of survival, that is called as recovery, and that is in all four chains of survival, that is 2 for adult, 2 for pediatric, both for outside hospital cardiac arrest and in hospital cardiac arrest. Emphasis on early epinephrine administration, that is within 5 minutes of cardiac arrest, and repeat dose every 4 minutes to coincide with alternate pulse check. Now this is something that has been added. Rate of breaths, now this is the most important part, and I am expecting one question here from this point. That is, the rate of breaths in pediatric age group has been now increased. That is 1 breath every 2 to 3 seconds. That is 20 to 30 breaths per minute for infants, 30 in children less than 1 year, 25 for more than 1 year. So the rate of breaths have been increased. Okay. Now advice to consider cuffed endotracheal tube in pediatric age group. This has created this thing. This is a CPR recommendation. Okay. This is not for anesthesia. In anesthesia, we still want to intubate a patient with uncuffed tube till 8 years of age. But of course, this is a cardiac arrest scenario. Risk of aspiration and proper ventilation is more of a priority than the subglottic stenosis and edema. Therefore, they have told to consider ET tube cuffed in pediatric age group. Okay. All right. Then 2 thumb encircling compression in infants is better than 2 finger compression. So we know that 2 thumb encircling technique is like this. So when you use it like this, right? So this is better than 2 fingers. Ventilation rate for adult is now 1 breath every 6 seconds rather than 5 to 6 seconds. So range hata di gayi hai. So they have tried to make it even more simpler. 1 breath every 6 seconds. Use of capnography is recommended even during bag mask ventilation, and use of mobile technology is reasonable. You can use your mobile for different things, for assessing the quality of CPR, for calling for help, for everything. Okay. ACLS. Now nothing much has changed in ACLS. Amiodarone and lignocaine are now considered equivalent antiarrhythmic. Initially they used to say first drug of choice adrenaline, second drug of choice amiodarone. If amiodarone is not available, then lignocaine. So lignocaine was second to second, but now they have considered this as same. So amiodarone, lignocaine both are equal as an antiarrhythmic agent. Second line. For adult symptomatic bradycardia, atropine dose is changed to 1 mg from 0.5 mg. So now you have to give a higher dose, 1 mg. Okay. 1 mg. Emphasis on prevention of hyperoxia, hypoxemia, hypotension. This is something that has always been there. They have just emphasized this fact that while doing CPR, you are not supposed to give too much of oxygen, too less of oxygen, and try to maintain blood pressure. Target SpO2 94% for stroke and general care, while for post cardiac arrest care, they have changes to now 92 to 98%. Initially it was 94%. Now it's a range 92 to 98%. Now during CPR, now this is an important part. 15 seconds before pausing the compression for giving shock, high performance team should check pulse, pre-charge defibrillator, prepare to deliver shock in 10 seconds, or increase the CCF2, that is chest compression fraction, to more than 80%, as 10% rise in CCF leads to 11% rise in survival. That means you have to not wait while you are performing the chest compression to give the shock. So there should be as less interruption as possible. So you have to increase the chest compression fraction to more than 80%, and IV is preferred over IO. This is something we already know. Our first route of access is always IV followed by IO. So these were the changes. Now let me just tell you, chain of survival recovery has been added. Keep this picture in your mind. For inside hospital cardiac arrest, recovery has been added. And what do they mean by recovery? It includes additional treatment, observation, rehabilitation and psychological support. This is what they mean. So it is basically something that happens after post cardiac arrest care. Happens post cardiac arrest care. After post cardiac arrest care. Now this is the most important slide. Difference in adult and pediatric CPR. Most important slide. Difference in adult and pediatric CPR. Now this is what will form the most important thing that you have to remember in CPR. Let's see the point of difference. Activation of emergency response system in adult. First activate ERS, get AED, then start CPR. In children where you have witnessed collapse, do the same. But if you see an unwitnessed collapse, that means you reach somewhere where a child or an infant is already collapsed, then you first give 2 minutes of CPR. Remember this point. First give 2 minutes of CPR. Then leave the victim to activate ERS. Alright. So this is the first point of difference, that is activating the ERS. Second is compression to ventilation ratio without advanced airway. For an adult it is easy, 30:2. But for a child or an infant, if there are one rescuer, 30:2. But if there are two rescuers, then 15:2. So again, more breaths are being given to children. The reason is very simple, because children, their respiratory causes are more important causes of cardiac arrest than cardiac causes. Compression to ventilation ratio, this is something that has changed with advanced airway. In adults it is 1 breath every 6 seconds, that is 10 breaths per minute. While 1 breath every 2 to 3 seconds is for now infant and children. Alright. So this is a very major point of difference that you have to remember. Depth of compression 2 to 2.4 inches for an adult. For children about 2 inches, and for infants about 1.5 inches. Alright. Hand placement. This is also one of the changes in the lower half of sternum for an adult. For an infant with one rescuer, it is one finger technique, but this is not considered to be very good. With two rescuer, it is thumb encircling technique, and this is also considered to be better than the finger technique. This is considered to be better than the finger technique. So these are the 4 and 5. 5 point of difference. 5 points of difference in adult and pediatric CPR. If you remember this much, this is more than important. I am telling you, you will get one question from here. Something that was asked 1 year back, that is triple maneuver. What is triple maneuver? So it is a set of 3 things that we do that opens up the airway. That is head tilt, chin lift, mouth open, jaw thrust. So head tilt, chin lift is 1. Head tilt, chin lift, you can see. Head tilt, chin lift is 1. Mouth open is 2. Jaw thrust is 3. So that is called as triple maneuver. Triple maneuver. Okay, triple maneuver. Next, defibrillator. There are 2 types of defibrillators. One is automated external defibrillator used in basic life support, while there is a manual defibrillator used in advanced cardiac life support. This is a completely automatic device. So what it does is, when you attach it, analyzes the rhythm on its own, and it only gives shock. Brilliant device. But a manual defibrillator is used in ACLS, where you have to analyze the rhythm, then you decide the energy, and then you give the shock. So energy, you have to remember, in a biphasic ventilator is between 120 to 200 joules, while for a monophasic defibrillator is 360 joule. Now we don't use monophasic at all. This is the new and this is the advanced version, that is biphasic. If you don't know what type of defibrillator is available, then always give maximum energy. Whatever is the maximum energy in the defibrillator, you use that. Okay. So now that you have to analyze the rhythm, how do you say what rhythm it is? So VF, VT are shockable rhythms. There are 4 cardiac arrest rhythms. VF, VT, pulseless electrical activity and asystole. Pulseless electrical activity and asystole. Out of this, VF and VT are shockable rhythms. while PEA and asystole are non-shockable rhythms. So when you have to give shock, these are the only two rhythms that will be amenable to shock, right? Now, if you ask me which is the most common cardiac arrest rhythm in adult and pediatric, asystole. Most common cardiac arrest rhythm in both adult and pediatric patient is asystole. All right. Drug therapy in CPR. Most important is adrenaline or epinephrine, which is also the drug of choice in CPR. Dose is 1 milligram. Dilution is 1 in 10,000. What do you mean by 1 in 10,000? You take 1 ml, dilute it to 10 ml. This becomes 1 in 10,000. Every 3 to 5 minutes. Every 3 to 5 minutes. If you are giving endotrachely, then 2 to 2.5 times the dose, 1 in 1000. Dilute it in 10 ml and then push it through the tube, followed by ambu bag. Okay. Amiodarone. First dose 300 milligram bolus. Second dose 150 milligram bolus. Lignocaine. First dose 1 to 1.5 mg per kg. Second dose half 0.5 to 0.75 mg per kg. 0.5 to 0.75 mg per kg. Alright. In pediatric, you have to remember adrenaline. Dose is 0.01 mg per kg. 0.01. If you talk about volume, 0.1 ml per kg of 1 in 10,000. Right? So 0.1 ml per kg of 1 in 10,000. Always remember IV you always give 1 in 10,000. Maximum dose is 1 milligram. So repetition is same after 3 to 5 minutes. Okay. Now reversible causes of cardiac arrest 5H and 5T. Hypovolemia, hypoxia, acidosis, that is hydrogen ion, hyperkalemia, hypothermia. 5H, 5T, tension pneumothorax, cardiac tamponade, toxins, pulmonary thrombosis, coronary thrombosis. 5T, 5H and 5T, right? 5H and 5T. So this is something that you have to know in CPR, the basics, okay? And you can expect one question from CPR in your exam. Now let's come to core anesthesia, and what I'm going to do is I'm going to take one topic from each section which I feel is the most important. So first, from pre-operative assessment is pre-medication. What is the goal of pre-medication? It is to make patient feel better before surgery. So acceptability increases. What all do you do? Anti-anxiety, analgesia, sedation, amnesia, anti-cyalagogue, anti-aspiration, prevention of nausea and vomiting, and antibiotics, right? These are the things that you desire in pre-medication. These are the things that you desire in pre-medication. Alright. So most common pre-medicant used is benzodiazepine. Why? Anti-anxiety, sedation, amnesia. All of this function of benzodiazepine. In benzodiazepines, the most common agent to use is midazolam. Why? Fast in onset, short in duration. Fast in onset, short in duration. Second most common, anticholinergic. Which anticholinergic? Glycopyrrolate. Why is it preferred over atropine? Because doesn't cross the blood-brain barrier. Doesn't cross the blood-brain barrier. Antibiotics. Timing is important. 60 minutes before incision. What is the ideal time of giving antibiotics? 60 minutes before incision. Ideal time of giving antibiotics 60 minutes before incision. Alright. So these are the goals of pre-medication. Next, agent of choice for specific conditions. So what we'll do is we'll take up a condition and we'll see which all agents do we use. So let's start with cardiac patient. What is our goal in cardiac patient? Maintain cardiac output. So we don't want both. We don't want sympathetic stimulation that increases heart rate, precipitates failure. We don't want hypotension and therefore decreased filling of the heart leading to strain on the heart. So we want to maintain cardiac output. So if we talk about opioids that we want to give, fentanyl is preferred. Induction agent, you all know. Most cardiostable induction agent, etomidate. Inhalation agent, isoflurane, maintains blood pressure, maintains cardiac output. Muscle relaxant that does not have any hemodynamic effects, cisatra and VEC. Alright, cisatra and VEC. So these are the agents that we give in a cardiac patient. But what if the patient is a trauma patient or somebody who comes with hypotension because of hypovolemia? Then your induction agent of choice becomes ketamine because of its inherent indirect sympathomimetic activity. It increases the blood pressure. So ketamine is only when hypotension is because of hypovolemia. If hypotension is because of cardiac problems, then etomidate is the drug of choice. Alright, neuro. Now you get two types of neuro questions. Either the patient is for neurosurgery or the patient has, along with neurosurgery, raised ICP, intracranial pressure. Something changes in between the two. Induction agent of choice for neurosurgery is propofol, while for raised ICP we consider thiopentone. Why? Thiopentone has maximum ICP decreasing property. Now inhalational agents initially are not preferred, but if at all we have to give, we give SIVO. Muscle relaxants. You can give any muscle relaxant you want, but you have to avoid scoline. Why? Scoline increases ICP. Okay? Scoline increases ICP. Alright? So for neurosurgery, you have propofol for neurosurgery, thiopentone for raised ICP. Alright? Daycare. Now in daycare you want to discharge the patient early, therefore you will give all the drugs that have short duration of action. Pre-med, midas. Opioids, remifentanil. Induction, propofol. Muscle relaxant, mivacurium. Inhalational agent, sevoflurane. Right? This is for daycare. Right? Now let's come to a question that confuses a lot of you. Liver disease or liver transplant. So again, liver disease or liver transplant, you want to maintain the blood supply to liver. Also because there is liver failure, so the action of certain drugs that are metabolized by liver will increase, right? So if you want to ask pre-med, again midas. Induction, propofol has extrahepatic metabolism, therefore it is safe in liver disease. Inhalational, now here most of you get confused. It is isoflurane because it maintains the liver blood flow maximum. Isoflurane maintains liver blood flow maximum. Isoflurane, inhalational agent. Okay. Muscle relaxant, of course cisatra and atra, because non-organ dependent metabolism. Okay. And opioids, remifentanil. Why? Again, tissue and RBC esterases metabolism. Tissue or RBC esterase metabolism. Alright, so this is about disease specific agent of choice. Disease specific agent of choice. This is where you get confused. Therefore, I've taken it this way. Otherwise, normally we take a drug and we see its indication. Here it is disease specific. Alright, let's come to complications. And two complications that you have to remember. One is malignant hyperthermia and another is venous air embolism. Okay, so malignant hyperthermia, you have to remember it's a genetic disorder. Defect in ryanodine receptor present on chromosome 19 that causes massive calcium release from sarcoplasmic reticulum. Massive calcium release from sarcoplasmic reticulum. So there is intense muscle contraction. What is the first sign of malignant hyperthermia? Sudden, abrupt increase in EtCO2. That is because of sudden increase in metabolism, sudden abrupt increase in EtCO2. While hyperthermia, which is the name of the condition, is actually a late sign. It takes time for the body to increase the temperature. So it's a late sign. It's a late sign. Diagnosis. How do you diagnose? So if it is pre-operative diagnosis, then the gold standard is caffeine halothane contracture test. Caffeine halothane contracture test. Caffeine halothane contracture test. While if it is intraoperative diagnosis, then most sensitive is increase in EtCO2. Most sensitive is increase in EtCO2. Let's come to management. Let's come to management. Let's come to management. For prevention, you will give trigger-free anesthesia. Trigger-free anesthesia, that means you can give all except scoline and inhaled anesthetic agents, because these are the triggers of malignant hyperthermia. Management, treatment. 3 points that you have to remember. 1. Drug of choice, dandrolin. Dose, bolus 2.5 mg per kg. You can give every 5 minutes. You can give every 5 minutes. Max 10 mg per kg. 10 mg per kg. And avoid verapamil. Verapamil. Why? CCBs increase hyperkalemia. Increase hyperkalemia. CCBs increase hyperkalemia. Okay. Alright. Now next, venous air embolism. You have to remember keywords. In the question you will get a sitting position surgery. Sitting position surgery. Sudden drop in EtCO2. Sudden drop in EtCO2. Sudden drop in EtCO2. These are the two most important things, right? Diagnosis. You have to use certain technologies. So most sensitive, invasive technology to detect venous air embolism is transesophageal echocardiography, TEE. Transesophageal echocardiography. While most sensitive, non-invasive is precordial Doppler. Precordial Doppler. Precordial Doppler. In management, the first step is always inform surgeon and flood the field with normal saline. What happens? There's a barrier that is created between the open vessel and the air. So it stops the entrapment of gas or air. Stops the entrapment, right? And second is bilateral jugular compression. Bilateral jugular compression, that will increase the pressure in the neck veins. Okay, so this was about venous air embolism. Next is monitoring pulse oximetry. Very, very important. What you have to remember, what are the factors affecting pulse oximetry and what is the principle? Principle is Beer-Lambert law. Principle is Beer-Lambert law. Beer-Lambert law. Beer-Lambert law. Mona, I have confirmed it is SIVO. When did I say ISO? For neuro, inhalational agent of choice is SIVO. So you have to remember factors that cause increase in reading. Carboxyhemoglobin. Actual the patient is hypoxic, but what you see on the monitor is 100% saturation. That is a false high reading. Factors that decrease in the reading, that is false low reading. Methemoglobin shows 85%. Methylene blue shows 65%. Maximum decrease is methylene blue. Indocyanin green, endocarmine dyes. Peripheral vasoconstrictive states like shock, hypotension, shivering. Badly positioned probe or motion of the probe, and this is a very important question. Nail paints, especially dark blue, purple or black. Dark blue, purple or black. Okay. Factors that have no effect on the reading: skin pigmentation, self-hemoglobin, hemoglobin variants like F, H and S, jaundice, fluorescein dye, acrylic fingernails, henna or mehndi, and polycythemia. Henna or mehndi, right? So these are the factors that change the reading of pulse oximetry. Very, very important. Every year in every exam we are getting one question from this topic, right? Next is capnography. Capnography, that is measurement of end tidal CO2, end tidal CO2, end tidal CO2. And now we will see a case-based approach. Case-based approach. So what you have to do is you have to look at the question carefully and see what kind of EtCO2 is given, whether it is hypocapnia or hypercapnia. So the range is between 30 to 40. So if it is less than 30, it is hypocapnia. More than 40, that is hypercapnia, right? Now in hypocapnia, what is that they are showing? Whether it is gradual or sudden. If it is gradual and it is decreasing, then it can be due to either hyperventilation or hypotension. Hyperventilation or hypotension. Hyperventilation or hypotension. Hyperventilation or hypotension. So increased CO2 washout. Increased CO2 washout. Increase CO2 washout. But if it is coming to zero, gradually decreasing to zero, that means it is esophageal intubation. In esophagus, when the tube is there, you get few signs, 2-3 waveforms which will finally go to zero. Shubhangi, you don't have to change. Masseter spasm is a premonitory sign of malignant hyperthermia. It is not the first sign, it's a premonitory sign. Go back and check your notes, right? So if it is going to zero, it is esophageal intubation. But what if hypocapnia is sudden? If it is sudden and the history is telling you that there is a sitting surgery, that means it is venous air embolism. It is venous air embolism. But if it is happening suddenly going to zero, that means either there is disconnection of the tube or there is cardiac arrest. Disconnection of the tube or there is cardiac arrest. Then what if in question they give you hypercapnia, that means CO2 is rising. Then again see whether it is gradual. If it is gradually and the graph is touching the baseline, that means it is hypoventilation. Hypoventilation. So there is CO2 accumulation. If the graph is not touching the baseline, that means there is rebreathing of expired CO2. That happens when the soda lime gets exhausted. Rebreathing of expired CO2, that means when soda lime gets exhausted, If it is happening sudden and it is happening intraoperatively, that means it is malignant hyperthermia. I told you, sudden abrupt rise of EtCO2. But if it is happening during CPR, that means it is ROSC, return of spontaneous circulation. Return of spontaneous circulation. Return of spontaneous circulation, right? So these are the case-based approach of EtCO2. Now, there are two waveform changes that you see. If you see something like this is called as shark fin. Shark fin. Okay. If it is shark fin, then it is bronchospasm. While if you see something like a normal graph but with an increased inspiratory time, that means it is faulty inspiratory valve. Faulty inspiratory valve. Faulty inspiratory valve. Okay. Now next is local anesthetics mechanism of action, and mechanism of action that they are sodium channel blockers. Sodium channel blockers. Site of action is intracellular surface. Intracellular surface. And when they act, then they do not change the RMP. No change in RMP. No change in resting membrane potential. No change in RMP, resting membrane potential. No change in resting membrane potential. Now, if they ask you what is the order of sensitivity of nerve fibers to local anesthetic, A is most sensitive, followed by B, followed by C. A, B, C. There should be no confusion here. Okay? A, B, C. In A gamma is most sensitive, followed by delta, followed by alpha and beta are same. Alpha and beta are same. Okay. Next is decreasing order of absorption from the site of administration. When you give the local anesthetic, what is the decreasing order of absorption? So blood, maximum absorption, followed by bronchial, that is intratracheal, intercostal, nerve block, followed by intrapleural, caudal epidural, followed by paracervical, epidural, which is lumbar, followed by brachial plexus, and finally sciatic nerve block, and least is subcutaneous infiltration. Least is subcutaneous infiltration. Subcutaneous infiltration. Alright. Now next is local anesthetic systemic toxicity. Very interesting. It can be CNS or CVS. What we need to know is CNS is first to appear. It is usually mild. CVS is later and is usually grave. For CNS, the biggest problem is seizures, for which we give small dose of benzodiazepines or barbiturates and maintain airway. Maintain airway. While there is no treatment for CVS toxicity, there is no treatment. Only thing that can help us is intralipid, which is a 20% lipid solution, which is given as a bolus dose of 1.5 ml per kg. Intralipid. It is the only agent of choice for bupivacaine induced cardiotoxicity. Okay. Next is central neuralgial blockade. It's a huge topic, but what they usually ask is cardiovascular effects after spinal epidural. So let's understand it in a retrograde way. We know after giving spinal epidural, there is sympatholysis. Sympatholysis. So there is pooling of blood in the periphery that causes hypotension. So depending on the level, you will always get hypotension with spinal or epidural. If hypotension is associated with tachycardia, that means the level of the block is below T4. It is below T4. If it is hypotension plus bradycardia. That means the level of the block is above T4. Above T4. Above T4 because the cardio accelerator fibers are also getting affected. Cardio accelerator fibers also getting affected. So there is hypotension and bradycardia. This is called as high spinal. This is called as high spinal. But what if the level keeps on going up, hypobradycardia, and there is aphonia plus apnea. So the patient is not able to breathe. This is called as total spinal. That is when the level of the drug goes higher up in the medulla, right? Higher up in the medulla. PDPH, post-dural puncture headache. This is the headache that happens after dural puncture. Why does it happen? CSF leak. CSF leak causing stretch on meninges. Stretch on meninges. Cardinal symptom is headache, which is either frontal or occipital. Frontal or occipital, right? It is increased by sitting, standing, straining. Sitting, standing, straining, and decreased by lying down. Decreased by lying down. Management. See, there are multiple symptomatic managements. We all know about that. Hydration, analgesics, stool softeners, even drugs like sumatriptan, which will cause cerebral vasoconstriction. But the treatment of choice or gold standard treatment or best treatment for PDPH is always epidural blood patch. Epidural blood patch. Epidural blood patch. Epidural blood patch. Alright. Anesthesia machine. Most important points. O2 flush. Something that you don't have to forget. Part of intermediate pressure system. It is not a part of high pressure system. Part of intermediate pressure system. Intermediate pressure system gives unchecked flow of gases at 30 to 75 liters per minute. 30 to 75 liters per minute of 100% oxygen. 100% oxygen used for emergency O2 supply. Emergency O2 supply. Remember, intermediate pressure system. Intermediate pressure system. Mapleson circuits. We know there are 6 types of circuits. A, B, C, D, E and F. B and C obsolete. A, McGill's type of circuit. Best for spontaneous breathing patient. Spontaneously breathing patient. D, Bain's circuit. Best for controlled ventilation, that is controlled breathing patient. E and F, pediatric circuits. When we say pediatric, less than 20 kg. E is Ayer's TPs. F is Jackson and Rees modification of Ayer's TPs. For all practical purposes, F is better than E. F is better than E. Okay. Next is endotracheal tube cuff system. Cuff system of endotracheal tube. Cuff system of endotracheal tube. So based on cuff, you have 2 types of endotracheal tube, 2 types of cuff system. High pressure, low volume. Low pressure, high volume. This high pressure cuff is seen in red rubber tubes and low pressure cuff is seen in PVC tubes. What is the advantage of a high pressure cuff? Best to prevent aspiration. Best to prevent aspiration. Best to prevent aspiration. While what is the advantage of a low pressure? Decreased risk of tracheal stenosis. Decreased risk of tracheal stenosis. Disadvantage of a high pressure? Increased risk of tracheal stenosis. Why? Because it will impede the blood flow to the mucosa. So it can later on lead to tracheal stenosis. And disadvantage of a low pressure cuff is increased risk of aspiration. Increased risk of aspiration. Alright. So these were some of the things that I wanted you all to know in anesthesia. Now everybody is asking about TOF. So TOF is a neuromuscular monitoring pattern. It is actually simple. What you do is you give 4 stimuli over a period of 2 seconds. It is also most common used pattern. Most common used pattern. Most common used pattern. Shagun, I have specifically told you for CPR the guideline is to use a cuffed endotracheal tube, but in anesthesia we will still use uncuffed tube. So if the question is CPR, you will answer cuffed. If it is not CPR, you will still answer uncuffed. There should be no doubt in it. Okay. Most common used patterns. So you give 4 stimulations over a period of 2 seconds, right? Now the 2 things that we see is TOF count and TOF ratio. Count means number of stimulations, number of contractions seen after TOF stimulation. And if it is 4, that means the muscle is not relaxed. And what you can do is TOF count is inversely proportional to the depth of relaxation. So more the relaxation, less is the TOF count. While TOF ratio is intensity of 4th twitch to 1st twitch. And under NDMR, TOF ratio is always less than 1 because 4th will always be less than the first response. At 0.7, you give reversal. And at 0.9 you extubate the patient. These are the 2 things that you have to remember. Extubate the patient. Okay. Alright. Alright, so this was my part of the must know topics for you in anesthesia, but in any case, if you go through your notes, it will take you hardly 3-4 hours to read the entire anesthesia. And I would really suggest that you go through every part of the notes because those are anyway high yielding topics. Okay. So you have a next session on, I think, pediatrics. Sir is waiting. So thank you so much and see you all next time. You can always ask me doubts on the club and I'll be happy to answer them. Okay.